So Evan, nobody was talking about radium. By the way, it's an alpha particle. We have been talking a lot about radioligand therapy in the last few years. As, you guys have been involved in a lot of the data coming out on that. So there is, at least that I know, one trial showing safety of radium followed by beta, lutetium PSMA, right? I'm wondering, do you envision a world where you actually have both available pre-chemotherapy, like PSMA4 if lutetium gets approved, or other agents? What are your thoughts about, you have an alpha particle, you have a beta particle. I don't think we're there yet to combine it. Maybe in the future we'll see what happens with combining alpha beta. But what are your thoughts about if you have RLTs available in the mCRPC setting, patient is progressing on ARPI, what can you tell us about it?
Yeah, I think it's not crazy to think about using both of them. I think the reason why I really like the PEACE-3 study is not just because there's overall survival benefit, and the hazard ratio for RPFS and OS was the same, 0.69. That's pretty impressive OS data, right? As medical oncologists, we love OS. I mean, that is the gold standard for us. But the fact that we all know that from the Alsimca trial years ago that there's survival benefit with radium, but we weren't using it that much because it was hard to find a place to put it. Right, because you had to have patients who had symptoms, yet they couldn't have visceral metastases, PSA doesn't drop, and if you're giving it as monotherapy, people don't like the fact their PSA is rising. It's just, we knew that there's benefit, it's just kind of hard to find the right patient and how to keep the patient on for 6 cycles. So the thing I like about PEACE-3 is that it's in combination with enzalutamide up front. It should drop the PSA in the vast majority of patients. Right. If you were to do it after abiraterone, let's say, it might be around a 30% response rate. So kind of takes PSA out of the equation. It takes the needing the symptoms out of the equation. And it gets you the opportunity to add another life-prolonging therapy in there earlier. And so with this, I could easily see, as long as there aren't major myelosuppression issues as we gather more data using alpha and beta, beta and alpha in different sequences, I could easily see the opportunity for all that to occur even before chemotherapy. Again, if you had a really rapidly progressive patient, they're just going to need chemo, but it depends on the patient.
I think there's less myelosuppression with radium than there is with lutetium and actinium. That's my experience. And I haven't used it for a long time now, but I think that there's less myelosuppression.
Pluvicto, or PSMA lutetium, when patients progress, it's commonly in the bone. That is a site of progression. So radium after PSMA lutetium is active and can be done sequentially, even with docetaxel sandwiched in between. So there is registry data and safety data around those sequences.
Yeah, very good point. So before we wrap this up, wonderful discussion, So I'll start with you, Cora. What do we expect in the future? What's coming? Can you walk us through, and I'll ask the same question to the three of you, or feel free to chime in. Novel MOAs, maybe the novel hormonal therapy coming, RLT, do you like to highlight, PROTAC therapies, ADCs? What is catching your eye?
I'm working with all of these different agents. And
what do you think it's closer to be available to us?
But I think what's important is that patients with metastatic disease have genetic testing and have next generation sequencing. And we need to know who's BRCA, and we need to know who could benefit from a PARP inhibitor too. It's something that we didn't mention. I think that that's really, really important. I see in New York a lot of Ashkenazi Jewish people, but it's not only them that have, homologous recombination deficiencies, and I think we cannot forget about that in that whole class of agents either. And then we have, the newer PROTACs that are very interesting, and the macrogenics molecule that's very interesting. There's many new interesting molecules that are around the corner. We haven't cured prostate cancer yet. I think we've improved the overall survival, but we still have a bit of a way to go until we can say we've cured it.
Got it. So Evan, what do you think we're going to be in 3, 4, 5 years from now? What do you think we're going to have new therapies available to us?
Yeah, I think I agree. There's a lot of interesting things. I think other immunotherapies, bispecific antibodies certainly look very promising. Maybe even CAR T cells. I'm a little biased coming from the Fred Hutch, but we do a lot of that work there. But if I may just make one big comment, it's the fact that there are a lot of good targets. And there are a lot of good targets that we've abandoned in the past. And the reason we abandoned is we didn't have good drugs. But I think...
Do you want to highlight some of them for the audience?
I don't think we need to talk about all the loser drugs in the past, but I mean...
No, not the drugs, but the targets. I mean,
but yeah, there's great
targets.
Okay.
You're talking beyond PSMA.
So yeah, beyond PSMA, right now there's B7H3, which is PDL2, there's TROP2, that's another great target right now. STEAP1 is another great target. There's a lot of great targets, but the key thing I want to emphasize is the drugs. And there's a lot of ways to target them, whether it's a bispecific, whether it's a CAR T, whether it's an antibody drug conjugate. I think a big deal in all of oncology has been that we've gotten better at designing drugs. Antibody drug conjugate design is so much more complex and important than just looking at, okay, I have an antibody that finds a target. Is the target expressed on the cell surface and does it stay there? Oh yeah, there's a linker that keeps some chemotherapy payload. It seems that simple. It's actually much more complex. You have the antibody internalization. You really need to know the stability of the linker. What's your drug-antibody ratio that's loaded on there? Are there off-target effects because of that? There's so many different components, but we're getting good at it. And I think you mentioned what's going to happen in 5 years. I'm going to say in 5 to 10 years, we're going to be using a lot less, very, very little traditional chemotherapy. And I think it's going to come in the form of antibody drug conjugates.
Fantastic point. So new targets coming. Andrew?
I like these points. I guess I'm going to divide it into two. One is I do think we'll be seeing more cures in 3 to 5 years because we're already seeing that with Stampede. AR is still the best target, and when you intensify treatment on AR in early, localized, but high-risk disease, we're seeing higher cure rates. So abiraterone for 2 years with ADT, very simple strategy, was very successful. But then we'll see Enzarad, Dazzle HiCap, and Atlas studies in the next 2 years. The cure rates are going to be higher. It's almost guaranteed. So that's exciting for our patients. They'll never make it to our conversations of CRPC management because they're not going to get it.
I agree with that.
And then the second is like, how do you think of CRPC, the unfortunate patients that present with metastatic disease and go on to get that? There's still AR is a major target. We're presenting some data tomorrow on an AR degrader, and I think that's going to go into phase 3. We've got xaluritamig, a STEAP1, that's going to go into phase 3. There's a lot of AR cofactors. AR is still really important, but we can't forget what happens when the tumor forgets about AR and then goes down a different path called lineage plasticity. And neuroendocrine prostate cancer is probably 20% of cases who are dying of prostate cancer. That is really a different disease. Different strategy, different cell surface antigens, different ADCs, different BiTEs or TRITEs or CAR T cells. It's different radioligands. So I think, stay tuned for some new targets for a totally different disease. Like tarlatamab was just approved in small cell lung cancer. We'd love to see that get approved in small cell prostate cancer, for example.